Welcome to our Grand Rounds. Good morning, and thank you for attending our Grand Rounds today. Today's lecture is a part of the Congdon leadership, and we are pleased to have everyone here. It's my privilege to introduce to you our speaker for today, Dr. Mercedes Carnethon. Dr. Carnethon is an epidemiologist and the Mary Harris Thompson Professor and the Chair of Prevention Medicine and Professor of Medicine and the Division of Pulmonary and Critical Care. She specializes in cardiovascular disease, obesity, diabetes, and lung disease with a particular focus on how lifestyle behaviors such as sleep and physical activities influence the development and management of these chronic conditions. Her impactful research has widely been published in leading scientific journals and been featured in major media outlets, including the New York Times and Chicago Tribune. Through her work, she has made significant contributions in advancing our understanding of the chronic disease prevention and management. We are grateful to have Dr. Carnation's experience on the important topics and look forward on her insight today. At the end of the lecture, we will have time for questions. Please submit your questions via the Zoom chat function as they arise during the presentation. We're also pleased to offer CME and MOC credits for today's Grand Round session. To claim your credits, please text a code displayed at the beginning at the end of the session to 804-625-4041. For any questions or to log on to your CME Cloud account, please visit VCU Cloud CME or contact Shannon Winston. Now, without further ado, I'll turn it over to Dr. Carnathan.
Thank you so much, Dr. Prabhu. I appreciate the introduction and am grateful for the invitation to speak this morning. Please let me know at any time if something strange happens with my slides or you're not seeing what you're supposed to see. Hopefully you're all looking at the title slide now. I'd like to take this opportunity today to talk about the paradoxical association of obesity with heart disease in older adults. And my interests in this area are because throughout my career, I've done a lot of work in obesity and other metabolic conditions. And lately, I've become very interested in how we think about obesity in older adulthood. I have no disclosures. I do want to start by thanking the Congdon family endowment for my invitation to today's to be today's speaker. So my outline today will discuss older adults and obesity, something of the epidemiology and background, the pathophysiology of obesity and heart disease with a specific focus on what is happening in older adults, and then spend some time discussing obesity management for cardiovascular prevention, for which we have a growing number of tools to use for management. So the obesity prevalence in the United States is high and remains higher. So the most recent files and data come from the 2017 to 2020. And we know that post-pandemic, we actually saw slight increases in rates of obesity. Overall, rates of obesity do tend to be highest actually in the middle age category of 40 to 59. Slightly higher in older adults, particularly among women. The estimates from Haynes are that 15 million older adults are currently obese. And almost 2/3 of adults in general are overweight or obese. Obesity, as we know, has serious implications for physical and mental well-being. And these serious adverse implications don't stop in middle age. Obesity is associated with functional limitations. We see correlations with cognitive decline. Again, difficult to determine temporality of that relationship. Obesity is associated with chronic mental illnesses, including depression, anxiety, high levels of chronic stress, higher healthcare costs. An estimate that I saw was that obesity globally is associated with $3 trillion in costs. Individuals with obesity tend to cost the healthcare system 30% more. There are also challenges with other medical treatments in the presence of obesity. One of the examples I can think about that we talked a lot about during the pandemic are really, being able to offer some of the respiratory therapies to individuals with obesity, given constraints on sizing. Chronic diseases that I'm here to talk about today, cardiovascular disease, as well as decreased quality of life and life expectancy. So the obesity paradox was really all the rage, I think, right when I was coming probably finishing my postdoc, and when I first joined the faculty at Northwestern University, we used to hear a lot about this obesity paradox, which is described as the observation of a lower all-cause mortality rate in individuals who are overweight and class 1 obesity. Class 1 obesity being defined as a body mass index between 30 and 34.9. This paradox is observed in the setting of some, but not all, fatal atherosclerotic cardiovascular disease and CVD risk factors. So we tend to see this repeating in a number of different settings. I thought this review was particularly interesting. So this was a meta-analysis of overweight and obesity and its association with all causes mortality. If you look at the figure on the left, we have a referent category of 18.5 to 24.9. And what we see in the overweight range, that's the BMI of 25 to 30, we do see an inverse association of overweight with all-cause mortality that's particularly strong in adults who are ages 65 or older. In the obese range, you can see that in all ages and mixed ages, you see a positive association whereby obesity is associated with higher rates of all-cause mortality, but you see a null association essentially for all obesity, class 1 and class 2 obesity in adults who are 65 or older. And so it appears to be a less steep or strong association in older adults. The obesity paradox and all-cause mortality on a global scale tends to show similar patterns. So these are findings from a pooled analysis of over 10 million participants from 239 studies around Europe, Asia, Australia, and New Zealand. Participants were followed for up to 14 years. And the three panels reflect ages 35 to 49, the middle age range of 50 to 69, and then 70 and older. And here's what we see when we look at these slopes. We can see in the younger age groups that I've got a dashed purple line around those estimates. In the younger age groups, you see a much steeper slope once you pass the referent category, which is the big box at 25, right at overweight. See a much steeper slope in the two younger age categories than you do in the 70 to 89s. The hazard ratio for all-cause mortality per 5 kilograms per meter squared, which is the unit that body mass index is measured in, is 1.5 and 1.4 in the younger age groups, but certainly much smaller in the older adults. The association with obesity and incident CVD and life expectancy in adults ages 55 or older shows a similar pattern. The mean age of this population was age 70 years old. And for incident CVD, you can see that there's essentially no association in the middle category of overweight, but a significant positive association in overweight or obesity. And these are people who did not previously have CVD but went on to develop it, whereby, again, men and women with obesity have a higher risk of developing CVD. However, among those without cardiovascular disease, looking at mortality and life expectancy, there's no association of obesity with mortality among those who did not have CVD. And then mortality among those with CVD, again, and so, I guess consistent with the hypothesis and description of the obesity paradox, obesity is inversely associated with mortality among adults who already have cardiovascular diseases. So to let that sink in, if an individual already has a diagnosis of cardiovascular disease, obesity does not appear to convey any added risks for mortality. And we'll talk a little bit about this later when we talk about the pathophysiology. In heart failure, what we see is that obesity does increase the risk for developing heart failure, most likely because of its strong correlations with some of the primary drivers of heart failure, particularly HFpEF, when I think about the onset of diabetes and obesity. Among adults with heart failure, overweight and obesity are actually associated with more favorable outcomes as compared to those who are underweight or normal weight. However, that does stop at class 2 obesity. So those with the most severe obesity have the worst outcomes. However, analyses that rely on body fat percentage, which certainly tells us more about what the risks are. Those, well, I didn't mean to say however, because those also describe better survival if an individual has a higher amount of body fat. And I will discuss a little bit about why we see these findings. And this panel here on the right is a meta-analysis of 22,000 adults who have heart failure. And what we see along the x-axis of the panel are categories of body mass index, low BMI, all the way up to severe obesity. And we see the line of unity at 1, and we see lower likelihood of total mortality in blue and cardiovascular mortality in green amongst individuals in the overweight, obese, and severe obese category, although the confidence intervals do admittedly get fairly wide and cross the line of unity. And the only category that does appear to convey risk or go in the opposite direction is for rehospitalization. So, these findings also do suggest in this large meta-analysis that obesity may not convey the same risks in adults with heart failure. And this, I think, is because when we think about the pathophysiology of obesity and heart disease, there are a number of unique features that I think help to explain the paradox that we see in older adults. Quite frequently in observational studies, and most certainly in clinical practice when you consider what you're measuring from your patients, we rely on anthropometric measures, including body mass index. Body mass index is simply a ratio of height to weight, and does not differentiate between body fat and muscle mass, so it does not capture body composition. It also does not capture body fat distribution. It ignores the distribution and where we would find adiposity in order to distinguish between central adiposity, which is a riskier form of adiposity, and peripheral adiposity. Another clear explanation that we often discuss is the muscle wasting with illness that we would see at the end of life, cachexia, whereby somebody's body in managing an illness starts to consume a lot of that protein and muscle in order to stay alive. And we also see differential associations and observations when we look at short-term mortality, when we look at the relationship of the short-term mortality with obesity versus longer-term associations with mortality. So with aging, when we think about how body composition changes with aging, the heavier components of total body weight are declining with aging. We quite often know about osteoporosis, and that is the decline in bone mass with aging. Osteoporosis is defined when that bone mass exceeds the norm and the expectations. Muscle mass declines 3 to 5% per decade after age 30, and that's without directed interventions and muscle strengthening activities in order to attenuate these changes in muscle. When aging-related muscle mass exceeds a threshold, it's termed sarcopenia. And these figures on the right side of the panel describe what healthy muscle mass looks like. You see the red muscle mass filling out the entire sphere that is a cross-section of the calf. And this is somebody at young age 25, for example, versus the lower figure, which is depicting muscle loss and sarcopenia. You see far more yellow fat, you see fatty infiltration into the muscle, and a smaller overall calf circumference. And when we end up with sarcopenia, sarcopenic obesity conveys health risks. There is quite often not just an increase in adiposity, but also a visceral fat, which secretes hormones that are detrimental to vascular function, inflammation, insulin resistance. individuals with more fat have an adverse profile of adipokines that are being released from adiposity and inflammatory markers that also influence metabolic diseases. So I always like this, I always include this slide when I'm talking to lay audiences because we know what we like in a high quality steak, right? So a high quality steak that's very flavorful has lots of fat in there. It has intramuscular fat. It has, you see the fat between the different muscle compartments, which makes for a delicious and high quality Michelin rated steak, but not really optimal for performance. So it's not just the size of the muscle when we talked about the calf circumference, but the quality of the muscle, how well the muscle is working. Is it taking up is it, the glycemic stores, are they adequate for energy and processing of glucose? Poor muscle quality is associated with decrements in physical performance as well as endocrine function. We've spent a lot of time within the field of obesity focusing on adiposity and fat mass and the hormones that fat secretes. But muscle is also a metabolically active endocrine organ that secretes hormones that affect the endothelium, the pancreas related to glycemic control, both the pancreas and the liver. As well as the bone, some of the myokines that are being released from the muscle. And muscle, though, is an interesting target and something to really think about because it can be modified by behaviors. It can be modified by muscle strengthening activities. In addition to changes in the muscle and increases in sarcopenia, body fat distribution is also changing with age. We talk about the classic apple shape versus pear shape, and at the premenopausal stage, more women tend to have a pear-shaped or gynoid distribution of adiposity, but postmenopausally, with the loss of estrogen and its protections, more weight moves to be above the waist and much in an android pattern that mimics what we most likely tend to see for fat patterning among men. And this distribution is adversely associated again with the release of various adipokines that are related to metabolism and cardiovascular functioning. So when we compare what we can get from waist circumference, this is a BMI and waist circumference in relation to cardiovascular disease at two different age points. The goal of this study was to investigate the impact of general obesity and central obesity on CVD risks. And I focused the slides here on body mass index. The next slide will look at the waist circumference associations. And this was in 1.9 million adults in the Korean National Health Insurance Database. And they were able to choose two specific points in time and follow participants for over 7 years for myocardial infarction and stroke. And what we see is a clear J-shaped association in middle-aged adults with a nadir of about 18.5. Shifted a very steep curve there, going back up as body mass index goes up, but a much more shallow curve, although statistically significant in the older adults in relation to body mass index. And in that same study, here are the findings as relates to waist circumference, a very direct association in 40-year-olds and a much more shallow, though certainly statistically significant association in the older adults when we look at waist circumference. So the adipose tissue, as well as the muscle, is an active endocrine organ that's releasing a number of different adipokines. And central adiposity is much more metabolically active than peripheral adiposity. And again, as we mentioned, aging is associated with a shift to the android distribution. These adipokines affect the blood vessels and circulatory systems. They promote insulin resistance and other metabolic diseases through the release of the following sets of hormones that reflect both inflammatory processes as well as appetite regulation and metabolism. So all fat in the central region isn't the same. We have subcutaneous fat, whereby fat is right below the skin surface. When an individual has subcutaneous fat, it is not typically associated with additional ectopic fat. Those individuals tend to have lower liver fat, epicardial fat, and lower muscle fat. By contrast, individuals who have visceral adiposity, whereby the adipose tissue is packed tightly around the organs. You can see there the fat is inside that region. Those individuals tend to have altered free fatty acid metabolism and an altered release of adipokines and infiltration of fat into the major organs related to metabolism, thus increasing the likelihood of metabolic syndrome, or now our current focus is the CKM syndrome. So globally, we don't know how many people have sarcopenic obesity. Part of that is that we use multiple different definitions to define it. But this particular study tried to investigate the worldwide burden and prevalence of obesity and provided an estimate of around 11% in a meta-analysis of 50 studies of adults who are over age 60. And they searched for studies that looked at the combination of obesity and sarcopenia. And the definitions were based on a number of different metrics, including body fat percentage, BMI, and waist circumference. You can see the highest rates being reported in the Americas and slightly lower rates in other regions of the world, resulting in an overall estimate of an 11% burden. Sarcopenia has, considerable negative health effects. Those individuals with sarcopenic obesity, much higher rates of cardiovascular and other complications, metabolic disorders, cognitive impairment, arthritis, disability, lung diseases. But also you can see the impact that the muscle is having. And again, this is a reiteration of some of the slides earlier describing what was released in muscle. Higher rates, with these changes, we tend to see higher rates of hospitalization, fractures, various cardiometabolic diseases, and decreased muscle mass. And again, I highlight the impact that this can certainly have on older adult independence and physical functioning as well as considering the ability to even adhere to rehabilitation should one have an MI. And part of why we see part of the obesity paradox, and when we think about why we tend to see lower rates of mortality, is that obese individuals tend to have a higher metabolic reserve, right? So they have more energy reserves and stored calories should they face illness. Those stored calories have higher protein stores with the obesity, particularly if muscle mass can be retained to some extent. Also mechanical protection from fall protection tend to have greater bone density in the setting of overweight and obesity. And having better nutrition is directly tied to the hormonal factors, better immune support to withstand subsequent illnesses on top of whatever the initial insult is. And so when we consider the obesity paradox in older adults, it is a real thing, right? So overweight or obese individuals do tend to live longer. However, when we consider at what cost, given the higher burden of metabolic as well as other cardiovascular illnesses, there are multiple biologically plausible pathways that link obesity and aging with cardiovascular diseases. We can observe many of those intermediates, glycemic disorders, hypertension, dyslipidemias, and inflammation, higher levels of inflammation and adverse myokines that are being released. The pathophysiology is of great interest of mine. I'm an epidemiologist, and we do some of these studies in population settings. But when I've been challenged to address the question about whether or not understanding the pathophysiological process will influence the treatment strategies, I think this is where a lot of the interesting nuance tends to come in when we think about how we should treat obesity in older adults with considerations of safety, which options will have the greatest benefit, and really which options are likely to be accessible to the largest number of older adults and to be something that is sustainable. But I think we have to start with the question of whether weight loss in older adults actually leads to better outcomes. And that answer isn't straightforward. In a meta-analysis of 30 studies, it suggests that weight loss is associated with elevated mortality in older adults. And I will highlight that these are observational studies. As compared with individuals who had stable weight, those individuals who lost weight had a 59% higher likelihood of mortality. In another meta-analysis of observational studies, a greater than 10% weight loss over 4 years was associated with higher cardiovascular disease mortality in older adults. Women almost 2 times higher likelihood, men almost 3 times higher likelihood of mortality when weight loss was apparent. However, again, as an epidemiologist, I always like to teach when I can. Observational studies have significant limitations, and this is a case where clinical trial evidence is probably much more useful because clinical trials have the benefit of focusing on intentional weight loss rather than inadvertently capturing weight loss that could be occurring secondary to some other pre-existing illness. In this meta-analysis, it included 8 trials that were predominantly middle-aged adults. Again, I couldn't find very much about meta-analyses in older adults, but these trials reported collectively no benefit of weight loss on cardiovascular disease mortality. It is not yet known whether or not these findings would extend to older adults, but you can see here on the forest plot, the big triangle at the bottom that summarizes across the studies really is showing right at the line of unity of no effect. So does lifestyle change? So even if we don't focus on the weight loss aspects, does changing lifestyle lower risks for cardiovascular disease? Lifestyle change that promotes weight loss is demonstrated to improve many aspects of health in older adults. Older adults who engage in these and do lose weight quite often are better able to manage their hypertension. Sometimes glycemic control can get better without the addition of meds, and sometimes individuals who are engaging in healthy lifestyle, you can actually lower medications that are being used. Quality of life improves, as well as osteoarthritis. And as I'm now older with bad knees and having, been a lifelong exerciser, I have to be thoughtful about how much pounding I can do on my knees. And so if I was hoping to be physically active to manage my weight, I also have to contend with osteoarthritis and how much burden and pressure I can put on my joints. The association of weight loss with cardiovascular morbidity or mortality is less consistent. Again, as demonstrated by those trials, and we are all quite familiar with the look-ahead study that was carried out in adults with diabetes that did not show cardiovascular disease benefits. Age wasn't a pre-specified subgroup, so we don't see those data specifically for the older adults, but across the population of individuals enrolled in the trial, there was no cardiovascular benefit associated with weight loss in look ahead, although we did see movement in the factors that were associated with the pathway. They improved their fitness, they did lose weight, some of the glycemic markers got better, but there was no translation to CVD benefit. Lifestyle treatment for obesity for older adults would typically consist of dietary change, either a healthy isocaloric or eucaloric diet, either holding calories steady so one doesn't gain weight, or taking in less calories so that one may lose weight, is certainly the cornerstone of obesity prevention and weight loss, as well as a way to manage various cardiovascular disease risk factors. Quite possible in older adults that special diets that really emphasize protein intake may be particularly important as muscle is being lost with aging. Physical activity recommendations in older adults. The guidelines that came out in 2017 do extend to older adults and emphasize 150 minutes of moderate to vigorous physical activity per week, with the addition of 2 days a week of muscle strengthening activities. And for older adults, that might consist of balance, focus on balance, as well as resistance training. I love this picture of the older lady here lifting weights. And whenever I'm working out, excited when I see older adults there handling heavy weights. It's very impressive. But there are a lot of requirements to promote successful lifestyle change in older adults. Part of it has to do with convincing older adults that this is necessary. There's a lot of polypharmacy in this group. There could be considerations there about interactions of dietary change with medications that the individual is already taking. Adapting lifestyle behavior changes in the older adult population certainly requires consideration about balance and safety in the types of activities, whether those activities, physical activities, should be supervised to reduce the risk of injury. However, when you think about supervising, it requires, either somebody coming to the person's house or them being transported to a center, and that's not always possible. So I always like to think about the contextual factors around lifestyle change, and then bolstering self-efficacy for adopting lifestyle changes. When I think about physical activity, the potentially or borderline almost frail older adult might say, hey, I don't feel safe walking around the block. I could fall. There's no way I could do that. But, creating exercise prescriptions that gradually build confidence in one and one's competence to engage in physical activity can really, work wonders for older adults, but needs to be considered rather than just handing over a lifestyle change prescription. We have a ton of options now related to pharmacotherapies to address obesity in older adults. And I had an opportunity last spring to present at the European Society for Preventive Cardiology about, it's part of a debate about whether lifestyle change versus pharmacotherapy was most effective for addressing obesity in older adults and what we should be doing. And again, some of what I'm sharing with you today has arisen and developed through that really wonderful debate that we did in Athens. The market for obesity pharmacotherapies has certainly grown, and with trial results suggesting that they are beneficial not just in individuals with diabetes for whom these therapies were initially developed, but also individuals with obesity. The number of people who are eligible to take these expands to over half of US adults. And that's because over half of US adults have overweight or obesity or a glycemic disorder that make them a candidate. There are many clinical trials, and I'll cover one or two of the most popular, one or two of the most recent that came out of medication classes. There are multiple clinical trials of not just the GLP-1s, but other medications that demonstrate effective weight loss in older adults, in adults of all ages. Few of them are focusing specifically on older adults, but I would argue that further study is needed to determine the risks and benefits among older adults, particularly since with the loss of fat, there are also losses in muscle. And this is something that's certainly been debated. When you're taking away some of the fat, the muscle needed to carry the fat is also going away. And physical activity in the setting of using one of these GLP-1s can help mitigate some of that muscle loss. Semaglutide is effective in adults with HFpEF. I was at the European Society of Cardiology meeting when this group presented the STEP HFpEF trial results that reported improvements in HFpEF amongst obese adults who were taking semaglutide. And they lost weight, they had improvements in symptoms and improvements in physical performance in the 6-minute walk test. The top panel is showing an estimated difference of 10, almost 11 percentage points in a body weight change in individuals in the treatment arm versus the control. And then the Kansas City cardiomyopathy score, symptoms of heart failure also improved markedly, a difference of 8 points in individuals using semaglutide versus placebo. The SELECT trial results came out shortly after that and were presented at the American Heart Association meeting in Philadelphia that year, looking at whether semaglutide can lower the risk of cardiovascular disease in overweight and obese adults without diabetes. This is secondary prevention. And in 17,000 patients with a mean age of 61, weekly dosing of semaglutide for 34 weeks. They were followed for 39 months. There was a statistically significant benefit to the use of semaglutide with a hazard ratio of 0.8. And it was associated with a lower risk of cardiovascular disease, the composite endpoint, which is what the figure displays, heart failure, CVD mortality, and total mortality. Results continue to come in. Most recently, I saw trial results indicating that semaglutide shows benefits for managing sleep apnea. I do a lot of work in the sleep space, and individuals with sleep apnea are much more likely to experience heart failure as well as cardiovascular disease and shortened mortality. Semaglutide is also associated with a lot of cravings, addictions, including food addictions and other unhealthy addictions. And so it does really appear that there are considerable benefits to the use of these GLP-1 agonists for management, but I would argue that additional research is needed, specifically in older adults, and it would be nice to see some of these age groups as pre-specified subgroups in trials. Another obvious, another intervention with proven effectiveness is bariatric surgery. Bariatric surgery is a tool that we tend to use in extreme obesity. What we can see in summary from trials and a meta-analysis of articles of 8,000 patients is that the outcomes in older adults, outcomes of bariatric surgery are similar in older adults as younger adults, associated with weight loss, resolution of diabetes, lipid changes, and these are comparable on average. So too are adverse or complication rates quite similar, so conveying really no risk. However, the eligibility criteria for bariatric surgery may exclude many older adults. Morbid obesity is a very small segment of adults with obesity, and morbid obesity, again, may be less common, so BMI is above 40 in the older adult population because of sarcopenia. There's the trade-off that fat weighs less than muscle and bone, and when they're losing muscle and bone, they may not hit that threshold for morbid obesity. As well, pre-existing conditions may make surgery very challenging. And again, treating individuals with bariatric surgery, it does require significant lifestyle changes and the health literacy to understand and enact those changes. So, I think we should, obviously, if we could step back and prevent the development of obesity in older adults, that would be optimal. But I do think that there is a route for treating it when it does develop. However, initiating preventive strategies in older adulthood may be too late. For example, what if the individual has had obesity for such a long time that the osteoarthritis prohibits weight-bearing exercises? Certainly individuals can get into pools to exercise or use bicycles, but those require equipment and access that may not be broadly available to all older adults. Treatments are safe. They do demonstrate benefit in older adults, both pharmacologic and surgical treatments. So those are certainly options. But I think getting those treatments to the populations at greatest risk is a remaining significant challenge. We find that obesity rates are higher among adults with lower levels of education. Socioeconomic disparities in obesity are apparent across the age spectrum. This is among women, but again, these same patterns are present among men. College graduates are in the dark blue, and you can see that the rates of obesity are lower in those populations than those with less education. These therapies are expensive, They require healthcare access, particularly for time and space for preventive healthcare discussions and debates. For a population who may be engaging with the medical system only in acute situations, they may not have time to discuss or address obesity on an already complicated problem list. So I would really argue that when we think about how we address and treat the obesity epidemic, we look at, we consider the health impact pyramid, whereby those interventions at the base of the pyramid that address the socioeconomic factors and the societal factors have the broadest impact on populations, whereas the top of the pyramid require the greatest individual effort. I highlight the efforts that really think about I highlight what it takes to get access to one of the GLP-1 agonists. The out-of-pocket costs could be quite substantial for those of you who had an opportunity to attend the American Heart Association meeting this year. There was a really excellent panel that was facilitated by Dr. Ndumale that met with patients to talk about what their experience was with GLP-1 agonists. And one individual cited paid somewhere around $1,000 a month. She had the access to the money to be able to pay it, and the health literacy to understand why it was important to manage her obesity. But that's a significant burden that every individual can't actually bear. And so we need to think about ways to change the environment. When I was the chair of the obesity subcommittee of the Lifestyle Council, I was able to participate in a paper that was led by my colleague Deepika Laddu, talking about implementation of obesity science and how we translate this into clinical practice. It's a very multidisciplinary field because it requires many different inputs to actually address the base of that pyramid to prevent the obesity in older adults and promote the uptake of evidence-based practices. Again, the goal of implementation science being to bridge the gap between research and practice by identifying strategies to ensure that evidence-based interactions are sustainably integrated into real-world settings. So, I really want to thank the sponsor of this lecture, as well as research funding support and my colleagues and collaborators for the work that we've done in this space and are continuing to do. Again, scientific collaborators and trainees, and also really my work and roles with the American Heart Association, which is where I've taken sort of a higher level lens and really viewed the work collectively of communities about how we can contribute to this and really think about stepping up to address overweight and obesity in older adults. So I thank you and wanted to leave time for questions.
Thank you so much for that. That was a very enlightening and a great presentation.
Oh, thank you.
Usually we don't think of obesity as we think of it more as like a general rule, like, BMI above a certain degree, and then we start thinking this person is already at a risk. It's very enlightening to know that your cardiovascular risk is very different based on where you lie on the curves and the obesity spectrum. What is interesting to me is like, why does use of medications of GLP-1 agonist, show benefits in patients with, when they're using it with cardiovascular mortality compared to those with like just weight loss in the higher age population.
So your question is, why is it that GLP-1 agonists are showing benefit for cardiovascular prevention?
Yeah. And
Okay.
if you look at the older age people, like above the age of 65, weight loss in general is not showing significant amount of benefits, just decreasing the BMI number, whereas use of, GLP-1 agonist
Mm-hmm.
is showing that there may be
Yeah.
a positive sign there. So where does the difference lie in there?
That's interesting. One of the things that I think is really exciting about GLP-1s is how much we don't know about how they actually work. They seem to work on so many different pathways and address so many different things. So, a couple of years ago, the American College of Sports Medicine had a whole campaign that is exercise as medicine. And it was emphasizing the pleiotropic effects of exercise on so many different systems, including mood, including physical and mental health, how exercise can do all these things. I would say that if I worked for one of the manufacturers of GLP-1s, I mean, talk about pleiotropic effects, and we don't even know all of the pathways. It does clearly appear to work on the brain in many ways. Um, I think, the original indication for which GLP-1s were prescribed was management of diabetes. Right, so lowering of glucose, increasing uptake and removal of glucose from the bloodstream and into the muscles. So I would suspect that GLP-1s, they certainly are lowering weight through some pathway, but they clearly have benefits on glycemia, which has a direct impact on morbidity and mortality from vascular diseases, and then the impacts that high levels of glucose in the bloodstream are having on the endothelium and on the organs that they're targeting. The impact I thought was very interesting about the sleep apnea finding. And now the apnea finding may just be secondary to the weight loss and particularly decreasing fat around the neck, but there could be other reasons why it's showing clear benefits for apnea. The addictions, the individuals who are finding that their alcoholism or their drug use or their food addictions are changing. What if it's possible that those individuals who are in a cycle of, high fat, high sugar foods, because they don't have the food cravings, maybe they are able to select more healthful meals that nutritionally have additional benefits. So, I think what my understanding of the field is on the biology side and the pharmacological side is that we don't even know all of the pathways by which GLP-1s are having such a positive effect on so many things. So I think there's a lot to be learned there. And we're really at the stage now with so many adults taking it that we're going to have the sample sizes available to us to look at some of these subgroup effects, particularly if we think about using administrative databases. I think about Optum and some of those insurance databases where we can pull together large scale numbers of people to look at some of this nuance.
That's a very good point, you know. It's not just that you're trying to treat a BMI number anymore. You have to understand what all is going in to get the patient to that point. And this presentation is very enlightening to me because we do get a lot of patients in that age group of 50 to 60 who are coming to us for like improvement in, quality of life and things along those lines. And just telling them that, your BMI is 32, you need to work on that to have a better cardiovascular mortality will not do for every certain patient, right? It depends on where the
Right.
trajectory of them lies on and how do you individualize to that patient. And from what I've been hearing, the best thing is just active lifestyle modification, the 30 to 50 minutes of, muscle training and strength training. That's what goes the longest way, it seems like.
Yes, I would really focus on that. I think one of the challenging things around obesity is it's personal and it societally is stigmatized. Individuals with overweight and obesity are treated worse than others in society. The medical field and its treatment of obesity has historically looked at it as a lifestyle failing.
Mercedes, hi, this is Greg Hunley. Thank you so much for delivering your presentation this morning, and then also all the work you do on behalf of all of cardiovascular medicine in your sphere of research. My question is, how do we reconcile the initiatives that the American Heart Association has to emphasize weight loss, combat obesity, with the massive amount of marketing in the food service industry that promotes food products that might just be counter to that. I mean, it seems like the dollar amount on this side is 10 to 100-fold of
Yeah.
what the dollar amount is on that side. And how do we get, or what's your perspective of how we might use other resources, whether it be through the government or policy changes or whatnot, to think about this issue?
Thanks so much for that question, Greg. And I apologize. It looks like I'm getting some signals saying my internet is unstable, so I apologize. A number of years back, I participated on the American Heart Association Industry Nutrition Action Panel, where the American Heart Association was trying to partner with industry leaders in the food space to really talk about and debate these issues. Obesity is big business, food is big business, and foods that are cheap to produce and can be mass produced and distributed in a shelf stable manner make people the most money. And they also promote overweight and obesity, which supports an entire industry. The American Heart Association, and particularly the leaders in the obesity committee have really tried to emphasize this. The American Heart Association is trying very hard to avoid stigmatizing obesity as a lifestyle behavior, and wants to focus as much attention as possible on modifying the environment. Some of the work that we've done on workplace wellness, really thinking about making workplaces healthier places where we can promote health and prevent overweight and obesity, has the potential to reach a larger number of people and workers, and has the return on investment for those industries that support the health of their workers. I do think policy changes and the work of the advocacy committees on the American Heart Association and in local American Heart Associations are one strategy to combat this. I've seen good data coming from the group out of Drexel in Philadelphia about sugar sweetened beverage taxes. Nobody wants them. People want to be left alone. By the time you tax things, by the time you create policies such as the trans fat bans that took place in New York City under Sonia Angel, those are policy level strategies that are meant to promote health. What we know from analogy in other countries is that these things can work. When the island of Mauritius recognized that they had the highest rates of cholesterol in the world, they banned certain types of fats in their foods and in food preparation. Politically, that sort of state interference on foods is not likely to be popular here. The American Heart Association, through advocacy, is going to continue to push for that. I think we all should, but I think the level of engagement that those of you who are clinicians are having with patients should create a safe space to identify strategies that can promote healthy lifestyles, because the over focus on weight leaves people feeling uncomfortable and stigmatized like it's a failing. And we have to really focus on what the overall environment is doing. And the overall environment is pushing us towards overweight and obesity. So it's going to take multiple levels of input to address the problem. It's so good to see you, Greg. When I saw you pop up, I was like, am I on the wrong call? But yes, we're
Yeah.
editors together on circulation.
Just to follow up, we tax cigarettes, we
Yeah.
tax alcohol,
Mm-hmm.
we tax, all kinds of things for different purposes. We tax gasoline so
Yeah.
that we can feed that money back into keeping our roads and infrastructure. It seems if this is, you mentioned these extraordinarily high percentages of individuals in the United States now, given that it's so prevalent, you just wonder, should we start to be thinking about small, and I know the prices of food and all this and, inflation, and we've had a big thing on that lately, but taxes and then putting these dollars back into prevention initiatives and doing things the way you've described, education of not making someone feel stigmatized. We've got to figure out a way. There's such an imbalance in what we see marketed to us on our phones,
Yeah.
everything on the food industry versus what is able to be disseminated through philanthropic organizations like the American Heart Association. I think we just need to think creatively about some sort of structure, as you've mentioned, with this other small country to address that.
I like your point. And in responding, I also want to build in this comment or question from Aditi Patel. about modifying the environment to promote health. I don't feel hopeful that taxing, so what we call sin taxes, right? So it's a sin tax to tax smoking because we generally feel smoking is bad, so we tax cigarettes and we tax alcohol. Sin taxes don't tend to go over well with the population, which says you can't tell me what to do. And the bigger problem is we see marked socioeconomic disparities in obesity. If we look at a population of adults with above a college education or a doctorate, the burden of obesity and severe obesity isn't going to be as high. Now, that's a population where if you tax the items, they can still purchase and it's not going to break the bank, right? So I think the feelings about the tax and what the tax is doing, perhaps people can step back and say, this is for the greater good and be okay with it. But what you end up with are lower income populations and populations with social adversity, where the real problem of obesity is. You end up with that population yelling, here's one more thing you've done to punish me and my group, and you've made things so much more expensive. So I'll share the story of what happened with the sugar sweetened beverage ban that was in place in Chicago for all of 2 months before aldermen and legislators said, no, you're punishing the very people who you're trying to help because it's going to cost us more to get our soda. Well, of course, the point was we didn't want you to get your soda. We wanted you to choose something else. But Pepsi Cola and the major beverage companies came in backing this, saying these are discriminatory taxes. And in hearing that these are discriminatory taxes where the pain is going to be felt by those populations that are being squeezed the most, ended up in a very rapid rollback. So essentially it failed to try the sin tax approach. I would argue, particularly I think in the current political climate where individualism has been a focus and a lack of government interference is a priority, that perhaps the government could interfere to do things like what we see in Europe that Aditi Patel points out, encouraging walkability, providing spaces and safe spaces for people to be physically active, building a better environment or using or subsidizing fruits and vegetables or farmers is a better approach. Now, again, perhaps the sin taxes that are already in place, if they're there, perhaps we can redistribute the money from the existing sin taxes into promoting a better environment. But I think all of these things, because they're personal, because they're political, we have to really make a case and use an approach that we hope we can get through to people and really appeal to what matters to them. When we think about employers and businesses, the return on investment, obese employees end up costing employers more because of more missed days of work. And health insurance costs are higher. So it is in businesses' best interest to keep their employers healthy and leaner. But again, to try to do so in a way that doesn't stigmatize individuals. There's a whole science out there about the stigma of obesity and how we need to address and discuss obesity and persons with obesity in the same way we would say persons with hypertension or persons with diabetes. Thank you, though, for bringing up, it's such a provocative and thoughtful point about how we go about doing this.
Oh, yeah, I can just see.
Mm-hmm.
Big deal.
Yes.
Well, thank you for these enlightening points. Really learned a lot from this, and taking an approach towards this topic is going to be different for me in my clinical practice as well. So appreciate your time here. We're almost towards the end of our allotted time, and this was a great grand round presentation, and thank you for everyone attending. If you guys have any further questions, please feel free to email Shannon or me, and then we will send them over to Dr. Carnethon, and then we can get a reply for y'all. And again, thank you so much for attending the grand rounds today.
Well, thank you so much for the invitation. Great to see you all. Take care.
Take care. Thank